The first thing I wanted to talk a little bit about was my research in tubing misconnections, because I think, there's no question about the error mode, what we call the error mode, of the way these things happen. But I wanted to let you know that I've talked to a lot of different people that have been involved in these. And the providers across the board usually say they don't remember doing it. So we're very convinced that this is the error mode that happens. My own research in this area is called cognitive workflow mapping. Big name for me sitting down with somebody and saying, here's a tube, how do you connect it? And then going excruciatingly through every single step that they do. And there's a lot of variation. People don't really think about how they do it. Going back to again this idea of they don't really understand how they're making these kind of mistakes. So very important for you when you think about it. When you think about moms taking care of kids at home, or you think about yourself when it's an off day, when you're not feeling well, that this error is very much a part of our lives and can happen to any of us. The other thing that I've heard, so I'll just give you my top list of things I've heard since I've been here. One of the things was a question about why hasn't there been any reported tubing misconnections in the literature since 2011. So let me tell you a little bit about reporting, because that is another area that I do work in. Healthcare reporting, we don't tell you about our mistakes. Just thought I'd mention that in case any of you didn't know. Hospitals have been known, healthcare has been known for quite some time in the United States for not reporting their errors. They just don't do it. There's a lot of reasons they don't do it. The first reason they don't do it is they don't like to get sued, is the first reason. In many of the states in the United States, if you say that an error happened with a patient, it's immediately a lawsuit. I work in the Texas Medical Center. It's 6 square miles of doctors and nurses and about 6 different not-for-profit entities. We don't even talk to each other about errors that happen. We don't share that information between us. One of the reasons is there used to be a big billboard right in the middle of the Texas Medical Center that said, call so-and-so to sue your hospital. And it's because they're afraid of lawsuits. That's one of the reasons. The second reason is they're afraid of each other. Nurses and physicians are some of the most punishing, punitive people I've ever worked with in my life, and I've been in this industry for 30 years. There's an old saying that nurses eat their young. Well, they may eat their young, but they chew on their old ones. Anyway, we do not accept from each other any mistakes, even though we make mistakes ourselves. And we punish people in training. We are constantly looking at each other, and it's ridiculous because we know that every human's going to make a mistake. So that culture, it's taking a long time for that to change. It's very much taking a long time to change from the regulatory aspect too. So every person with a license that touches you in the healthcare setting reports to a licensing board, be that the Board of Medical Examiners, be that the Board of Nurse Examiners or Pharmacy. And each one of those can take a complaint from a consumer, or from anyone actually, where they go in and make a complaint. And when that happens, they launch an investigation. And I will tell you, a lot of the people that have licenses live in fear of being reported to their board, because the board, again, may not be aware of these kind of errors. And so what ends up happening is they lose their license, or they lose, or they have some kind of penalty. I'm aware of one tubing misconnection that happened in the state of Nevada where a nurse lost their license. I'm not surprised when I see people punished otherwise. So there's 2 reasons you don't report. The third reason is this: we're human. And no matter who you are and what you do, you want to think of yourself as the best. So it's really difficult for us to report when we almost make an error. And really, that's where people learn things, right? Is not making an error, and then you almost made it, and then we can all learn. Don't do that in healthcare. We don't say to our neighbor, oh, by the way, I almost misconnected that tube. You got to watch out for that. We just don't share that information. I'm telling you things that are hard for me to talk about because they're not right. I mean, that's not right, but that is the way things are in healthcare right now. To that, I'll give you evidence if you haven't looked at it. The original report from the Institute of Medicine that came out that said that we were killing people in the United States somewhere from 34,000 to 98,000, that was originally authored by Dr. Lucian Leap. They have recalculated it, and the report came out just this last year, this many years since that report came out, and they think we have not reduced errors in healthcare at all. So it is not surprising to me at all that we don't have any in the literature. I will tell you, the first case that I found in the literature was from 1972. The first time that I ever saw a regulatory body say this is wrong and it needs to be changed was 1996 for the AAMI group. But that we don't have a report since then doesn't bother me. And I'm going to give you permission for something today, all of you, in case you needed permission. The next time someone asks you, why aren't there any more reported deaths since 2011? You have my permission to say, shame on you. Because it really doesn't matter how many deaths there are, there have been too many. So you have my permission to tell that person, shame on you. This is about every individual that has been harmed by this. This is about every patient, every nurse, every physician, every pharmacist. And we owe them to change this. So the next question I would say is, why do we need a standard? And why isn't there a standard? So here is where things get really complicated. I'm not happy about this either, but it's just kind of the way things are in the United States. And that is that no one regulatory body has said, we're going to be the ones that regulate this and we're going to tell you what to do. The FDA, although they have done some very good work in this area, has not stood up and said, we're going to regulate this and tell you what connectors to use. You know, in the United States, we have a grand tradition of everybody kind of doing their own thing, and freedom's important to us. I think that freedom has hurt us in this area because we have not standardized it. If you look at other countries, you look at the United Kingdom, what you will find is they have been able to do that. If you look at Japan, Japan's been able to do that, but the United States has not. So the FDA, even though they would enforce or they would review a connector, they're not going to say nobody else can make another connector. And there's going to be lots of connectors that are out on the marketplace that are made by people that never went through the FDA. That are things that you can probably buy on eBay or, you know, someplace like that. You're going to find those. The important thing to remember is this, though, is that way that we make this mistake. And for you to think about that when you're buying your own supplies and you're dealing with your own condition. If you have a feeding tube, you want to make sure that if you end up in the emergency department, that we can connect to you. And I'm not as worried about the feeding tubes as I am worried about the central lines access on some people that it's really difficult for us to get access to you. And I'm seeing the physicians in the front row going, yes. Because when you're in an emergency situation, the last thing you want us to do is to struggle to be able to get fluids or medicines to you. You want it to be effortless. So we need a standard. I would say I'm very disappointed we don't have a standard, but we do not have a standard. So that has not happened to date. So that was kind of my 3 points that I got from wandering around. So do you want to wait for questions afterwards, or would you like for me to start now? I have a little bit of time I'd like to give to Dr. Mundi. Okay, that sounds good.
Thank you, Dr. Simmons. I'm sure that you'll have an opportunity to talk to us more about your passion. And I know that you have a lot of passion for your subject. I am going to introduce Dr. Manpreet Mundi. He is back close to home, Southern California, the University of Southern California, is where he got his medical degree and also did his residency. But now he is at the Mayo Clinic, and he has been doing a lot of work with enteral nutrition, along with his colleague, Dr. Ryan Hart, who unfortunately is still in Rochester. Is he here? He's on his way? Well, that's good. I'm glad he's on his way. Anyway, he was delayed by a plane flight, so Dr. Mundi is going to take the entire road and do it. And I told him that I would introduce him as a world-renowned physician. And after he makes this presentation, he will be.
All right, thank you so much, and thanks for coming despite the great weather we're having. I miss this the most. But yeah, as we were saying, so Reinhardt is somewhere in the air. We think over Salt Lake City. He's making his way. We had some bad storms yesterday in Minnesota. But what I want to do, and I've been borrowing time from others because this talk may be a little bit long, but I just want to go over all of the research that we're doing to make sure that ENFit really meets the needs of our patients. So I'll go through that. The slide I want to start with is the disclosures. I don't have any disclosures. There's no financial interest. I don't have any financial relationships with anyone involved in this entire process, and I think that's key to mention. So what I like to do is, and I don't have to do much of this. I think Debora did a great job. So the benefits of ENFit, especially with the misconnections, but then describe some of the areas we've focused on in terms of testing. So I'll start with this, and again, the concept of there's no misconnections that are occurring because none have been reported since 2011. That's not a good way to look at it. In our institution even, we routinely see these instances keep happening. Just in the last few months, we had a tube that fell out where residuals were being checked and were checked in the balloon port instead of the feeding port. And so this stuff keeps happening, and that patient had to go back to the OR. Another case I can recall is where the patient had a venting G and a feeding J and was fed the wrong way and aspirated. So it's still a common issue, and we just had this slide kind of listing all of the cases. It's hard to follow Debora, but again, too many deaths. So we do need a solution to this, and fortunately, many of the companies listed here have come together to form GEDSA, the Global Enteral Device Supplier Association, to come up with standards for making sure that these enteral tubes don't misconnect with IVs or other ports. Now the transition, we kind of won the lottery in terms of enteral devices in that we're making this transition first. However, this transition is going to happen with others as well, Foley catheters, IVs. So this is just in the start of what's happening over the next few decades. And this is kind of that transition line. I'll go through these slides. And how many of you have seen this transition adapter? Oh, great. So perfect. So the transition is already starting to happen. And the way it's happening is from the feeding end onto the tubes. So even at our institution, we're starting to see that the feeding supplies are switching over to the ENFit connector. Right now, in order to make this compatible with the current tubes that we have, you're kind of seeing this, what we call the Christmas tree transition adapter. So that allows us to connect those feeding supplies to the tubes and continue to feed. This is, just more pictures of this adapter. But soon, we're then going to have introduction of the ENFit tubes themselves. And I think this is where, and I use this picture, so we took a lot of these pictures before I came, because this is the picture that's probably causing a lot of the angst behind it. So you take the ENFit prototype or the tube in itself, and most of us will hold it and just start looking right at the barrel of it and go, oh, it's a smaller bore. This is going to be a problem. And so that's essentially where we started this entire process, a few years ago. Just looking at the prototypes we could get a hold of, we were like, oh boy, is this going to work for most of our patients? This is a big change if you look at the two. So with that, we sat back as an organization and looked at, well, what are the areas? What are people doing with these tubes? One, they're administering medications. Another is they're doing gravity feeds. So is the flow rate going to be the same between the new tubes and the old, which we started calling legacy at that point? can our patients vent through this, and then also blenderized tube feeding. So I'll take the next few minutes to kind of go through details about this, and then we'll have question and answer afterwards. But just to give you an idea of why we're so concerned, we are one of the largest home parenteral and enteral nutrition programs in the country. And essentially, I pulled some of the data from last year. We trained about 100 new patients to give parenteral nutrition at home last year, and 700 new patients to do enteral nutrition last year. We're actively managing about 150 patients ongoing for parenteral nutrition at home. This practice has just continued to grow, and Dr. Kelly handed that off to Ryan Hurt just recently. In terms of enteral nutrition, we're now touching over 1,000 patients a year as far as our practice is concerned. So if anything goes wrong, it's really long days for me and Ryan Hurd and our entire team. So we need this to work really well. Just some more information about our programs and when they were founded, and overall how many patients we've trained, over that time. But if we keep going, so when we looked at, the issues, the first issue that started to come up, raised by a number of different organizations, was medication dosing. So I want to go through the details of why this could occur. So this is our engineers helped us make this schematic of the current tube. And you can see that the main thing with the current tube is that it's a female end to it. So if you have a feeding syringe, a medication syringe, that has a male port to it that goes inside this female port. With the NFIT, that gets changed. So here in purple, sorry, I'll try to point it out here too, but here in purple, you can see, it's not going to work, but you can see that that's the NFIT tube. And then here, we had them do, I don't know what color this is, green, I guess, but that's the syringe going on top of the NFIT. So you can see with the NFIT, it's switched. You've now got a male port there, and the syringe becomes the female port that gets inserted there. This has to do with that lure lock kind of mechanism, the locking mechanism, to make sure that only NFIT syringes fit with NFIT tubes. That's the whole misconnection issue. But this raises a bigger issue in that, especially, and I think this is where more of the problem is, when we're dealing with volumes that are quite small. That's where you're getting sometimes up to 10% over and under dosing, comparing if I was to use an NFIT syringe and give oral feeding versus giving it enterally through the NFIT adapter. So there's an overdosing. This problem, and I think Neomed was the company that came up with this pretty ingenious solution to this, of converting that NFIT syringe back into a male port. So they took the female port, and now there's a male piece, as you can see, inside of it. And so with this, it seems to have solved that issue. Again, major testing needs to be done, and there's an independent firm that's actually doing this testing. I haven't seen the data that's come about from that, but we want to make sure that, this dosing issue is resolved. So that's one. The second is the flow rate. So most of our patients in the hospital, whether they're getting gastric feeds or they're getting jejunal feeds, they're usually using a pump. When they go home, most of those gastric patients are actually doing gravity feeds with a bag like you see here. So this is a big concern for a program that has over 1,000 people that can call us and say, hey, things are going wrong. And again, looking at this view, you start to wonder, is the flow through these going to be the same? So with that in mind, this is kind of the testing that we devised. Obviously, it would take us hours and hours, perhaps days, if we were to test like 500 cc's of volume in a bag and do this through multiple formulas in triplicate. We just couldn't get it done. So we used kind of a syringe method to replicate that gravity feed and do 40 cc's of formula through that syringe and measure the time it took for the formula to flow. So kind of replicating gravity flow. We did this comparing the current tube And at that time, we were able to get a hold of a prototype of the NFIT. And when we did this, we had two prototypes. So NFIT A and NFIT B. And I personally like to be blinded to the tubes because I don't want to be biased in any way. So that's how I'll present the data. And this is where we started to see a difference. So this is kind of a big graph, but what I've done here is shown you the 24 French prototypes. And here in seconds is the flow rate. And then here are the formulas that we did. And each of this test was done in 3 triplicates. So that's the standard deviation of those. And you can see our team did pretty well in terms of replicating 3 times what the testing is. And you can see that the NFIT A took much longer. Whereas NFIT B, in some of the cases, especially with this isosource 1.5, actually was faster than the current tube. So this, right away we started to go, because if it's an issue with NFIT, why is NFIT B faster? And so I'll go through this more. That was a first thing that struck out for both of us in terms of what this data meant. The second was that obviously NFIT A, which was a prototype, was just not performing as well as the current. So that was 2 points we took off. The issue was mainly with the 24 French. Issue got better, as you can see, comparing current to NFIT A and NFIT B. The issue got better with the 20 French, so as we started to get smaller in size, the flow rate started to become the same between the 3. But in terms of that 24 French, NFIT A was just not performing as well as we would like. NFIT B, again, with certain formulas, was doing much better. So with that, we presented this data at one of the Oley organized conferences in November. FDA was there. Many of you were there. And that really got us in terms of developing a collaboration to fully test NFIT. So we formed a collaboration with Oley, with the FDA. So there's 2 scientists from the FDA, GEDSA, many of the manufacturers, and we've been, conference calling every other week, trying to make sure that we develop protocols, how to test NFIT, and then if we find any design issues that could be improved, how to make it better, essentially, and that's what we've been working on. So this is then what I call round 2. Similar way of testing, we've got IV poles, we've tied the syringes there, and then we filled the syringes up to 60 cc's. That's what the FDA, wanted. So we matched their protocol, so 60 cc's, and then we just measured the time it takes to do this. And so this is what I call our lab. You're going to see Wanda Duhlman there, one of our dietitians. All the formula is there because all of a sudden we went from testing 2 to now doing like 1,000 tests. So this was a major effort to do. And I've got more pictures of the entire team. One of our poor summer interns, I don't think he knew what he signed up for, but he's there. And then Lisa Epp, I think I have a better picture. So he is smiling though, that's the key. But they're all smiling, so it's good. But as you can see, so we're doing all the testing in triplicate and kind of making sure we've tried to do everything as standard as possible. But this is what the data shows. And it's a lot of data, it's a lot of testing, but the bigger picture from this is that it's so variable. In some cases, so essentially what you're seeing here, and we've labeled them, just becomes small for the back of the audience, but we've labeled them Legacy 1, 2, 3, and 4. So those are the current tubes. These are the 14 French, 18 French, 20 French, 24 French. And the Legacy are the current tubes. The NFIT, E1 and 2, are what they're transitioning to. We're still waiting for E3. That wasn't ready yet. I just wanted to show this data for this meeting, but we should have it soon and be able to do a true test. And again, you're seeing variable results. That's what's striking to us. In some cases, the NFITs are doing better. In some cases, they're not. So that's striking, because if it's an infant issue, they should all be bad. And so that's a point I want you to take away. The second issue we're identifying here is, you can see some of these infants are standing out. As an example here, the E114 French, you'll see this theme running through all the next few slides. There's something going on there. And we've been exploring with the manufacturers, and in addition to switching to the NFIT adapter, they also switched the tube in itself. And so is that playing a role? This is all what we need to figure out to make sure NFIT is going to work well for everybody. So I'll go through the next few slides quickly, but just this is more to show you the formulas we used as well. And you can see again, that 14 French NFIT 1, you know, there's something there. So we did Jevity, we did Isosource HN, Isosource 1.5, 2-Cal HN, and even Nourish. And this gave us a broad spectrum of formulas that we tested. What we did was we matched some of the formulas with the FDA to make sure that we were getting similar results, and other formulas only the FDA is testing. So as we put it all together with the FDA's data, we should get a big spectrum of what's going on. Okay, so then those were just the raw data. What I wanted to know was, well, how does it compare to the current tubes? So we reanalyzed the data. So this is, again, it becomes a mess just because there's so many tests that we're doing. But so here what you're seeing is 14 French, 18 French, 20 French, and 24. So everyone can turn their neck if they want. But essentially what we're doing is comparing NFIT to its legacy counterpart. And then the 1 means it's the same. If it's less than 1, it's doing better. NFIT is actually performing better. If it's worse than 1, it's performing worse. So by plotting data in this way, we start to look at patterns. The NFIT 1, I brought this up a couple of times, there's something going on in terms of that 14 French NFIT 1. So that's sticking out for sure. With others, you can see some of the NFITs are performing much better. Others are not. So I'll go through the same sort of slides here, Jevity, 1-Cal, Isosource. You can see the results are so variable. In most cases, NFIT is equivalent. In some cases, it's worse. And again, that 14 French, there's something there for sure. So when we looked back at this, very puzzling, because if it's an NFIT issue, it really should be, you know, I guess performing worse in all cases, but it's not. So we had our engineers go back and start to dissect the tubes. So what I've done here is, this is from that first round of testing that I showed you, where NFIT A didn't do so well, but NFIT B did much better. And I compare that to the current tube, the legacy tube. And as you looked at that picture, you saw that the NFIT has a smaller bore. And so we thought it was the smaller constriction that's causing all of the problems. But when our engineers dissected it, he said, wait a minute, when you go beyond, the internal constriction is about the same in all the tubes. And so with the legacy, my little laser's going out, but with the legacy, you could see the numbers there, 2.6. That's the smallest constriction in the current tubes that we have. So it's not actually wide because it goes down and narrows. You can't see that with just looking down the barrel of it. With the NFIT A, 2.5 is the smallest constriction. With NFIT B, which did so well and performed better than the legacy, the smallest constriction is 2.65. And then it opens up. So again, tube design, I think, is going to make the biggest difference here. By this opening up, it's kind of like the freeway transition. You know, I grew up in LA, so I know these freeways well, but I was driving from LAX, and I noticed the LA County to Orange County switch, you know, where the 405 just goes to 10 lanes, and all of a sudden traffic is moving 100 miles an hour. So that may be the issue here. is that if we can design the tubes in that manner, perhaps they'll actually do better than the current tubes. So that's one. Venting is another issue. And this is another one we're working on to make sure that our patients who need to vent can do so. And you know, common scenarios here are someone who has gastric issues like gastroparesis. They first need to vent from the gastric port, but with medications or just with time, things improve and now they can feed. We want to make sure they don't need to transition the tube at that point. So that's one of the things we're working on. Do we design a tube that has two ports, a venting port and a feeding port? So those are things, you know, we need to consider. The final part of this that we need to consider is blenderized tube feeding. I know this has become a big issue, and this is something we were not aware of at all. Even though I'm the medical director of this practice, I didn't know the things you guys were doing with your tubes. But now, you know, we've done more. And so one of the first studies, you know, our dietitians were always telling us patients are putting beer down there and all sorts of things. So one of the studies we did was we just asked our patients. We took a survey. We designed the survey, we validated it, and then we gave it to our patients and asked them, and more than half said, oh yeah, I use blenderized tube feeding. That was a shock. I literally thought it would have been like 5%, but more than half were blending their own food. So this is a questionnaire, and this study's been published in NCP, I think last year. And we published the questionnaire online as well, so you can go through the entire questionnaire, but just asking questions like, do you blend? How often do you blend? How do you blend? Those things, and why. So these were some of the responses of our patients. They said, it's more natural. You know, a lot of times they want to be part of the family and want to eat what the family's eating. Some of them said they do it for better tolerance. So variable results. But the striking thing was it's done often. So most of our patients were doing it for 4 or more days. You know, and they were meeting most of their nutritional needs with blenderized tube feeding. So this was really surprising. You know, those who weren't doing it, some of the main answers they said was, I'm concerned about safety. Can I do this safely? Is there an infection risk? They were not even aware of blenderized tube feeding, didn't know how to do it safely, and others said it's just too much time. I just like opening a can and it's easy for me. So then we partnered with Oley because we were always worried. You know, Mayo is, it's some hardy people there weather-wise, and so we just want to make sure, is the rest of the country also, you know, similar to this? So we partnered with Oley and put our same survey on Oley website. It was very quickly answered by over 216 patients. And the advantage of Oley was that we also got a spectrum of the pediatric population. Busy slides. Again, this paper has now been accepted. I actually just got the email this weekend. Will be coming out in NCP very shortly. But the big finding was that from the Oley population, 90% of the pediatric group said they used blenderized tube feeding. So it was way more, you know, than we imagined. In the adult group, it was around 66%, so 2/3. But again, similar findings. Most of the patients were doing it quite often. So if you look at days of the week, 93% of the peds patients said 7 days a week. Key is, again, you have to keep mind of survey results, because who's the patient that actually clicks on the survey and answers it. So there's always inherent biases. You're always picking more active patients. We're now partnering with GEDSA and many of our infusion companies to give this survey on a broader basis to try to capture a more national population. But still, it's not the 5% I would have said to begin with. So there's a spectrum, you know, somewhere in there, but the majority of patients are engaged in blenderized tube feeding in some capacity. So this is another thing that we have to test for. And this is sort of what we're calling phase 2 in terms of our collaboration with the FDA. And this is some of our preliminary work where we essentially prepared blenderized tube feeding and then measured how much force does it take to push that blenderized tube feed through the syringe, comparing that to the current tube. And this is what we're thinking will sort of replicate, a patient's thumb pushing on the syringe. Is it going to be just as easy, or is it going to be requiring a lot more force? This is, again, very preliminary data on a prototype, but this is what that data showed. There's a slight increase. So we did Jevity, and there you can see that the NFIT actually performed better. We did Liquid Hope as well, and not too bad. Quite similar results. It was when we got into the thicker foods, that's when the NFIT started having issues. And again, this is the early prototype. Our next phase with the FDA's collaboration is to then capture most of the NFIT tubes and repeat this testing with those to again make sure that they're behaving in a similar way. So that was the data, and a lot of it was preliminary, but I wanted to show that data just to give you an idea of everything that we're actually testing. Again, the California law that Debora mentioned is a driving force behind this transition. And for us at Mayo Clinic, really the timeline becomes, making sure that NFIT meets the needs of our patients, and then working with our partners in industry to make sure that if we see some kind of flaw, if there's a better design that we can, have, that we can meet the needs of the patients in regard to all of this. So I think that's all I have. So thank you. Do I just questions? Yeah, it's tough to estimate. So the estimates that are thrown around are anywhere from 150,000 up to 350,000 patients using enteral nutrition at home. That's been the estimate. What we're actually trying to do, and these are what's all published in literature. Yeah. Yeah. No, so exactly. So what we're actually doing is this is, again, I don't know how this came about, but Ryan and I were sitting somewhere. We're going to ask for Medicare data because they capture this. So we filled out the forms. We're asking for Medicare data, and then using Medicare's data, we're asking our infusion companies, the major infusion companies, to give us a ratio of how many of their patients are Medicare patients, and then trying to back extrapolate this to, yeah. So that's what we're trying to do. So I think that'll be more accurate, but this is the numbers I quote. I can't say for certain, but this is what's been reported in various studies and literature, and they've done all sorts of different extrapolations to get these numbers. So we don't actually know how many patients are out there. But we've filled out the form, so it's Medicare timeline will dictate. Yeah, no problem. Yeah, please. Yeah, no, absolutely. So we're facing the similar issues, and the way we're addressing this, we've started a pilot, and we're almost done with it, of blenderized tube feeding. You know, by giving our patients, I think we're using a magic bullet, because we want to use an economical blender, and having them do blenderized tube feeding at home. The main reason was our IRB would not allow studies on blenderized tube feeding due to safety concerns. So it wouldn't even allow it in the hospital because of safety concerns of bacterial contaminations. We pulled all of the literature on this, and there was not a U.S. trial. Definitely not one from Minnesota where, you know, you just put things outside and it's a freezer. So, you know, we think it's safe to do blenderized tube feeding, regardless of what we think our patients are doing it. So we're starting at this point, and then what we want to do is develop recipes. So we've asked Oley, and many of the members of Oley sent us recipes that they use. We're going to test them for nutrition, and then test them for safety, those kind of things, and then blend them up and measure their viscosity. You know, is this safe? Is this too thick? And then as we go through this, we're going to try to collaborate with Oley and even develop a blenderized tube feeding subsection. Almost, that's our hope, and other, you know, other groups as well, and really come up with the recipes that meet all the nutrition needs, and then give us a good, you know, viscosity in terms of being able to administer safely. So that's our approach. It'll take us a few months to get there, but I think we have to open it up because of the surveys, and we have to be able to give it in the hospital. Yeah.
For patient satisfaction, trying to, you know, meet their needs as much as possible without harming them. So I just wondered what other facilities are doing.
Yeah.
But thank you.
Right now, we're having our dietitians actually review the ingredients and then give us an idea if that meets their needs. It's labor intensive, but it's what we've got. Yeah, please.
It helps me to simplify to think of the pathway from a can to the stomach. I use a 140 cc syringe, big diameter, and there it goes into an extension set, smaller diameter but still a good size. From there it goes to my Mickey tube. The smallest diameter that I see is the final push into my stomach, the bottom end of that Mickey tube that goes through the balloon. Is that correct? Is that the smallest diameter that it has to go through? And isn't that the most important to the flow rate?
The smallest diameter is, and it seems that not only the diameter, but then what happens afterwards, because it could sort of create this increased flow, you know? So if there's an opening afterwards, and this is the key point, I think we have to dissect all these tubes, compare the flow rate, and see which tube is working better and why.
But isn't the pathway that is the most constricted, the most critical to the flow rate?
So in terms of our testing, that didn't work out, because when we looked at the legacy, the constriction was around 2.6. The infit was 2.65. I mean, that's a very minute difference. But it seemed what happened afterwards, where the NFIT B opened up, that led to a better result than the current tube that we have. And so our engineer was thinking it's that design of a constriction and then opening up that led to.
I'm not making my point very well. It isn't the infit connector diameter that I'm concerned with. It is the diameter of the final point of entry to the stomach. Yes, into the stomach.
Absolutely. That's what we saw with the 14 French.
That is the smallest diameter that any of the formula goes through, blenderized or commercial, right?
Yep.
So wouldn't that be the most important factor in what does slow down the flow rate, the smallest diameter?
Absolutely.
And isn't that diameter going to remain the same?
I mean, and that's
the point of entry is always going to be the smallest diameter, right?
Yeah.
It's the point of entry from the G tube, where the formula actually comes out of the tube into the stomach, that's the smallest diameter of all.
I don't know for sure, yeah. Okay.
If I'm understanding, he was talking about the entry actually into the body as being
Yeah.
the size you're concerned about. Is it right there, button circle? It's not.
Yeah.
It's actually smaller than that.
The tube afterwards. No, I absolutely I mean, and we're tearing these things apart to kind of answer your question. I just don't have the answer right now. But this is the point I was talking about. There's a lot you can do with the design. And I wasn't sure if this is the smallest constriction or if the tubing in itself is even smaller. But in terms of flow rate, this was the constriction, but then there's an opening here, and it goes to 2.85, and that going from 2.65 to 2.85 seems to somehow just open things up and things flow better. So I think the point is we just have to analyze all of this and then design better tubes if we need it. Yeah. Sorry.
I have a follow-up to the question over here earlier. Oh, I'm sorry. I have a follow-up to her question about the hospital. My son is 9 years old, and he's 100% blenderized diet. And my local children's hospital here in Orange County allows a blenderized diet in-house for parents to bring in.
Perfect.
With no questions asked.
Okay. So this is great for us to hear because I think it's happening nationwide and probably due to you as parents really demanding it, So it's a great thing.
Okay, on the tube there, what brand is that?
That I don't know.
Because different brands have different openings.
Yep.
And mine is much larger than that. It doesn't taper down from here straight on through. And
But that's the point is that we couldn't tell. So if I can show you this from the outside, this tube doesn't taper down.
right, but when you take infit and with the 2.9 inside bore and compare that with any low profile tube, which is all 3.0, there's not going to be much difference. But most blenderized tube fitters, like me, use the big bore 24.
Yeah.
And when you're using a 24 with about nearly a 5 millimeter opening inside, well over 4, and compare that with 2.9, that's where the blockage comes in.
But that was the point I was making because I have I don't know, now we may have to go too far back. But when you looked at the tubes, maybe I will go back. We've got time, right?
You see, on the 24 French low profile material, you still only have a 3.0 bore.
So when we look at these tubes, right? When we looked at the tubes, the diameter looks hugely different from the
Right.
eye, right? And so this is exactly our hypothesis, what you're saying. Oh man, this is not going to work. Look at the diameter. But when we had our engineers, I'll go back to that schematic, we had our engineers dissect this, and they were great to do this for us. You can see it wasn't this external diameter. It wasn't even what it looks like on the outside because he shaded in the plastic component of it. So when you feel it and you hold it, it looks like this is a big tube that goes all the way through. But then he actually dissected it and looked at the inside of your current tube, and there's a 2.6 constriction.
Right, but not in all tubes. I have a shop. I've taken machines.
Oh, you've cut
drill
yours
bits,
apart? Okay.
And I've inserted a precision drill bit measured in thousandths of an inch, and I have determined that there is a huge difference. And so, it's like taking a Pinto and comparing a Pinto Ford's lowest tar and comparing that with a Lincoln Continental and saying, well, they compare. They do not compare.
Manpreet, what French are these? Do you know?
I was thinking 20. I could be wrong now, yeah. This we did a while ago. If there's engineers who designed this, you could help me out.
So I have a question in regards to the study that compared the flow rates, and you talked about the legacy against the NFIT 1 and NFIT 2, and that one was better or worse.
Yeah. Yeah, I can go.
So, but is faster better? Is slower better? Or you just want it to be the same as the old legacy? Because as long as it goes in,
Yeah.
because I'm always trying to get my patients to slow their tube feeding down because they're trying to do it too fast and then they
Yeah.
don't feel well. So slower to me is not necessarily worse. I certainly don't want them to have a lot of effort to do that though.
Our concern was the reason they give it so fast is they want to go do things. So the worry we have is that, and I don't, again, this is anecdotal, but in cases where things slow down, they underfeed and we lose weight. And so this has happened when we see patients back and we're like, we're giving you like 2,700 calories, you know, you weigh 100 pounds, why are you not gaining weight? And they're just not giving it, doesn't fit into, so that's our concern with the slowness. But yeah.
So on your studies that you did, especially with like the 14 French, so I guess would those be relevant if somebody was using a pump to feed with? I mean, would the NFIT still run slowly with a pump, or would it make a difference then at all?
With a pump, I think you could override it because the pump may have force to it. That's why we went with the gravity route of testing this, because that's truly just gravity pushing the formula through. With a pump, with most rates, it may just have enough force to it that it could just push things through. So we don't know. Obviously, we have to do that testing, but that's become kind of less of a concern compared to this. Yeah, we think the pump, and this is a hypothesis, but we think the pump will override.
The breakout sessions are taking a break at 3:45. We can continue the discussion and not take a break, but those who'd like to get coffee or visit the restrooms, certainly feel free to do so now. And we'll reconvene with everybody here at 4 o'clock.
Thank you.
Hi.
Yeah, and it should be able to hit the green button.
Oh, is it back there? ladies and gentlemen. I never know if this is on. I think everybody can make their way back to their seats. Or not. There we go. Just a few more making it in. If we can get everybody settled, we've got 2 more speakers and then some time for some discussion afterwards. If you've joined the program late or halfway through, my name's Terry Edwards. I have the honor of being Oley's president this year. And my cohort in crime is Rick Davis, the other facilitator for this afternoon. Those of us who are tube feeders, we know that, it's an adventure that nobody wanted to undertake. It often comes as a surprise. And with that, there's as many problems as there are solutions, and as many solutions as there are problems. That being that there's usually one or more ways to fix an issue. And I know from personal experience that, getting together with, fellow consumers, I learned that term here. I thought that was so good. I came here as a patient years ago and left as a consumer. That just made me feel taller right there. But in sincerity, we learn, we struggle, we make connections. We're fortunate to have, organizations like Oley that are kind of a brain trust of things. I share with you things that, I'm now on a simple Mickey tube system now, but originally I was on a large regular tube and a J tube. And one of the first conferences my wife and I attended was in San Diego. Second day there, the tube had cracked below the fitment. So basically, right around the stoma, it had a leak, it cracked. So because that, I was 100% at the time reliant on the tube for both nutrition and hydration. I was 100% NPO. Total panic, like, I'm from Canada, do I go to an American hospital, what do we do, bang, bang, bang. So in the mix of all this, we're going up to my room, my shirt's all wet, we're trying to figure out, I've got my finger on it, what are we going to do here? And I've run into her before and long since forgotten the name, but always remember the event. The nurse, who was quite used to seeing what was going on, looked down and said, got a leak? And I said, yeah, look at this. And she said, go to the gift shop and get some crazy glue and just dry it off, and dry it off well, pinch it off below the break so it's dry, and put a crazy glue patch on it. Well, that lasted for 3 days, and I got home and had radiology sort me out, but who knew? Long since out of that tube, but you got my suitcase, there's crazy glue in there, too. Yeah. So it's my pleasure to introduce our next speaker. Cynthia Reddick we were talking earlier, like this is someone with over 20 years experience of hearing stories like everyone has here, hearing the horror stories, trying to figure out fact and fiction. And she's made it a passion. She's been a great resource for us in Oley. And in her work, she's come across, there's been things she's seen, I'm sure, that keep her up at night. But it's great. We're very fortunate to have Cynthia spend some time with us today. So call you up, and the good news is your slides are loaded and you're ready to go.
Thank you so much for having me. I'm going to test this out, make sure I know what I'm doing here. Oh, right, it worked. Excellent. So, I'm delighted to be here. I'd love to know who my audience is, so I'm going to do a little survey before we get going. So raise your hand if you are a consumer or a caregiver of a consumer for a tube-fed patient. Excellent. And raise your hand if you're a dietitian, either in industry, home care, acute care. Excellent. Nurses. Excellent. Pharmacists. Pharmacists. Okay. All right. Well, thank you for that, because I like to know who I'm speaking to. I do have, I'll call it a disclosure. It's more of a warning. My pictures are going to be a little bit different than Dr. Mundi's, so just be aware of that before we get going. And we're well after lunch, a little bit before dinner, but I do have sort of a case study style of presenting. I like to tell the story of the patient journey. I love to pull the curtain back and show what happens when people go home on tube feeding. My story is that I feel like home tube feeding is Wild West meets MacGyver, and I think that we just heard about that with the super glue. I've seen some things. I've seen super glue in connecting tubes and adapters and things of that nature. The other thing I want to let you know is I'm not going to talk about NFIT, and I'm not going to talk really about blenderizing. So we're going to go off the reservation here a little bit. You guys ready? So here are the objectives. Your tube feeding shouldn't hurt, and I'm going to be talking a lot about tube site complications, access device issues, infections, things of that nature. And then through some case study style presentation, just examples of how to set yourself up for success with your tube feeding, making it work for you at home. And then I'll touch on some different securement devices and adapters and parts and pieces, as I call them, to help you on your way that you may or may not know are out there. So, as you know, most tube feeding tolerance is really assessed at a clinical level with nausea, vomiting, that sort of a thing. But I like to talk about tube-related issues because I think it's sort of an unspoken, lesser-known field, and fewer people are willing to kind of pick up the ball and run with solving the problem when it comes up. So I love sharing my experience with you and really indoctrinating you, particularly the dietitians in the room. When I'm done with you, you'll be part of my army, okay? Because it's up to us to help identify problems, solve the problems, and really improve people's quality of life. So there are physician objections to dealing with tube-fed patients because it can be labor-intensive, and they're a bit out of reach for most physicians. Most physicians are not seeing patients on a regular basis in their clinic. They're not drawing labs on them once they go home on tube feeding. Particularly our adult population is a little bit out of reach. And so then physicians become very dependent on suppliers, home care providers, infusion companies, DME companies to be the eyes and ears on and help feed that information back and maybe even show up with a recommendation on how to solve the problem. So the concern is that there are lots of clinicians out there that aren't really familiar with how to solve some of these problems. So I hope to make you more familiar with them and have you walk away with solutions in your pocket. So I'm going to tell you a little story about Debbie. That's not her real name, but that's what we're going to call her today. And she entered my universe with a complaint about leaking at the tube site. She shockingly did not complain about having pain at her tube site. I learned later she had an extremely high pain tolerance. But she complained of leaking. And so what we do in home care often is we help troubleshoot by use of pictures and texting or emailing pictures to help solve the problem quickly because we're remote and we want to keep them out of the hospital. So this is not good. There's something wrong with this picture, correct? Right? So at first glance, to me, it looks like that tube's a little bit too small and it's clearly irritated. There's an infection going on there. So what I learned, I actually went to her house. It was a random stroke of luck. I was going to be near her house on a Sunday afternoon after a tennis match. So I asked her if I could come by, and she said yes. So this was up in Northern California where I live. So I went to her house, and this is what I saw. It was ooey gooey, and I wanted to learn more about what a day in the life was like for Debbie. And so I asked her to show me how she does her feeding, bolus fed, 6 containers a day of a 1.2 standard fiber containing formula. And so I watched her lay everything out. We went to her little, it was like one of those, what do you call it, like a bar in but she had it set up for her tube feeding supplies. So we went over there and she pulled out her syringes and her formula and she proceeded to do her tube feeding, what I refer to as a power feed. And I have never seen somebody shove formula through their tube so fast in my whole life. And she took that 6 dc syringe and shoved it through so fast, and I was sort of shocked. And so I said, okay, well, let's slow down. She finished that one container, and I wanted to hear more about her feeding regimen, but I was tricking her by just having her tell me about it so we could slow down before the next container, because she would do 2 containers 3 times a day. And so what she explained to me, and she had a lot of leaking, was kind of the primary problem, which is really evidenced by the massive yeast infection that she has there. Her G-tube site was constantly leaky and wet. So she proceeded to walk me through verbally how she feeds. She would do 4 ounces of a Pedialyte solution, and then she would do 2 containers of formula, and then she would do 8 ounces of water, another 8 ounces of water, and then 4 ounces of water. That's a lot. So I was, my eyes were wide open, and I said, well, let's go on into the kitchen and let's simulate that into a bowl. So we got a mixing bowl and we got a measuring cup, and I said, let's simulate that. And we poured 4 ounces, 8 ounces, 8 ounces, 8 ounces, 8 ounces, 4 ounces, and that was 1.25 liters. This woman's 74 years old, 5'3", 120 pounds, and as far as she's concerned, she didn't have time for this watering and feeding. We said it earlier, tube feeding for her was something that she had to squeeze into her day because she was busy. She was not homebound. She was out and about and had sewing class to go to and visit friends, and so she was going to power feed, and she nicknamed herself Speedy. That was her nickname to her friends. So I re-nicknamed her, told her that your nickname now is Little Miss Not So Speedy, and you need to slow down. So when I showed her that mixing bowl of water, and I held it up to her and showed her, as I'm holding it to her stomach, I said, this is too much volume, too fast. You need to slow down and respect your body. All of this is reverse engineered from a leaky tube complaint. This is what we were getting these calls from her about this leaky tube. There was something wrong with her tube. So what I learned is that she was too speedy, so we had to slow her down. So when I showed her the bowl and she got to sort of see that and then realize, okay, I do need to slow down and see the bigger picture, she then exclaims to me, and this is a woman who's been on tube feeding for 5 years. She's not new. She's been doing this for a while, right? And she just was going about her life and doing this fast feeding. But she says to me, well, that explains why when I bend over to pick up something after I feed, I vomit. Because she was folding over her stomach. And I said, yes, that's why you need to slow down. So it was a strategy session with her about fitting in a slower feeding regimen into her lifestyle. And so we talked about ways to incorporate that hydration divided up throughout the day, like in between those 3 feedings. And so that was a negotiation. And we do a lot of negotiating in home care to make what we want as clinicians fit with the lifestyle of our patient, of our consumer. And then we also talked about, this is another good part of the story, is she had this yeast infection from this chronic leaking, and she had nystatin in her home, which is an antifungal, and she had been using it as well as a barrier cream, which is what I was going to recommend for her. She needed to go on a rotation of an antifungal and a barrier cream. But what she was doing was she was putting the antifungal on top of the barrier cream. So it wasn't working. So it helped me as a clinician understand I need to be very specific with my education. The barrier cream is necessary, but we need to wipe that off before we apply the nystatin or the antifungal so that it will actually work. So that's helped me become a better clinician when I do teaching, because I encounter a lot of yeast infections with feeding tubes. So the other thing we did was I sent her out a stoma measuring device, so she was able to measure her stoma. Her button was too small, so we got her resized, let the physician know, got new orders, shipped out a new button, and then you can't really tell from this picture, but there was improvement in the yeast infection as well. Okay, so that was Debbie. And Debbie was a post-radical neck dissection, radiation. That was her story. And David had a very similar story, same diagnosis, ironically also in the state of California, but unrelated, but very similar time frame. They intersected my life at a very similar time frame. So I was able to apply the things that I learned with Debbie to David. Now, David showed up much grumpier. He was not a happy camper. That's why he's got that emoji. My daughter would be very proud of me right now using emojis. But he was not. He was very grumpy on the phone with me. We spent a lot of time talking. He was constantly having to cough and had this foamy sort of reflux that he was constantly having to manage. He would not leave his house. He would not go anywhere because he was having to spit and clear out this foamy reflux so often. He was tired. He was underweight. He was malnourished as far as I'm concerned. And his tube site was often very gooey. And so in learning about his feeding regimen, very similarly, he was a power feeder. And so he was feeding things too fast, and that's why his stoma site was leaking as well. I had to double check his button and see if it was properly sized, and we measured it, and he was sized fine. What was happening was he was just feeding too fast. But he did have a little hypergranulation here. You can sort of see it. I'll show you some better pictures of that as we progress. But and that was causing this ooey gooey. And this was a picture of all of the different things that he was applying. He was cleaning his stoma site with alcohol prep, which I don't recommend. I don't want anybody in this room to clean their stoma site with an alcohol prep. It works great for infusion and IV access, but for tubes, you don't want that alcohol on the stoma site. It will actually grow hypergranulation. And then he had I don't have my glasses on. I think that was his triple antibiotic ointment cream, which is not effective with actual infections. So I had him stop doing that and just did some re-education about slowing down his tube feeding. He was using a 2 calorie per ml supplement and was just powering through because, again, with his life, this watering and feeding, he didn't have much time for. And then the other major life changer, so this is where as a dietitian, I stepped out of my lane a little bit, but I wanted to help him with that reflux, and so I talked to our medical director about suggestions for him, not realizing that foamy was really just evidence of reflux that needed to be medicated. And so I made a recommendation for him to take back to his doctor for an anti-reflux medication. It changed his life. Why did nobody else think of this for him? I have no idea. But the little home care dietitian got it figured out. So he then started going out and visiting friends and doing things. He started selling the things that he was a collector. And so he opened up his eBay account, started selling things, and just started plugging back into life. All because we were able to make these little adjustments. And he was underweight, and we were able to get him to feed his prescribed amount because he was not refluxing as much and feeling so sick all the time, just with those little adjustments in his feeding regimen. So, like I said, he did the prokinetic agent. And then we changed his cleaning regimen, just soap and water, no alcohol needed, and then did confirm that properly sized button. So what is normal healing of a G-tube site? It should look like your pierced ear, right? So if it hurts and it's red and it's inflamed and gooey, it's not right. There's something wrong with that, and it needs to be addressed, even if your physician or a nurse or anybody has told you it's normal. It's not, okay? And I'll show you some examples of that. And a tube site should heal and stop with the crusting after 2 to 3 weeks, and then after that it should look like a pierced ear. So in the research, I found that infection at the tube site is the most common complication, with an incidence ranging from 3 to 30%, but I think that's underreported just because of how many people I've encountered walking around with infections gone untreated. So I want to introduce you to what a bacterial infection could look like. When I show this to my hospital colleagues, they freak out because there's like regular hands with no gloves on there, but I have to educate them about in-home care. We don't wear gloves when we're caring for ourselves. So that's what that picture was. The wife took a picture and she peeled back. That's a stoma, or that's a stat lock there at the stoma site. So that's what you see. This story I want to tell you about because it was one of the most profound ones I had ever encountered. This woman had had her feeding tube for about a year, and this was baseline for 10 months. She intersected our world because she had been at home with this tube feeding. She did not have a home care provider, so she was buying Ensure at the store, it's a Medicare patient, and was going in, I don't know, she had been in 2 or 3 times to have the tube replaced because she kept complaining there's something wrong with this tube. Yeah, there's definitely something wrong with that. You have a massive bacterial infection. So when our liaison was called in by the GI physician who was like, enough with the new tubes already, let's have somebody come educate her maybe on how to clean it and that sort of a thing. So I had never seen a bacterial infection quite this bad, and so what we recommended for her was a course of antibiotics that goes through the tube. Generally, I don't recommend, it was Cipro, like an oral Cipro, but flushed through the tube. And generally what I do when I'm recommending treatment for bacterial infections is topical, because I don't want to wipe out the entire GI tract with a systemic antibacterial. But in this case, we went big guns, and within 1 week, you can see the improvement. I think the worst part of the story is that this woman was feeding bolus feeds with a 12 cc syringe for 10 months. That's all she had. I changed her life with a 60 cc syringe and had her doctor call in an order for Cipro. These people are out there. So it's really about education and letting everybody know that there are, proper cleaning regimens. You do not need to be all alone out there. Oh, we also changed her life by billing Medicare for her supplies because she qualified. So that was the other big deal. So they're out there. So I want to talk quickly about hypergranulation. Hypergranulation is hyperplasia, or it's like an overgrowth at the stoma site, also known as proud flesh, and I'll be showing you some pictures of what this looks like. It's very vascular. It bleeds very easily, and anybody I've ever talked to that has hypergranulation has complained of a pain at a scale of 8 to 10, never below that. So hypergranulation is not benign as far as a patient's quality of life. And so when I see it, I want to make recommendations to help treat it. And I want to talk to you about what the causes are. So oftentimes it's from excessive movement of the tube if it's not secured well, if the tube's sort of flopping left and right or moving in and out. That will cause hypergranulation, or using alcohol, whether it's rubbing alcohol or hydrogen peroxide. That's how you grow hypergranulation. And occasionally it can be the body's own response to the presence of the tube, but generally I find another reason behind hypergranulation. So how do you treat that? The best way to begin is to use a hydrocortisone cream at the stoma site and do that for a couple of weeks. And if you don't see improvement at that point, then that's something that you would want to bring back to the physician and let him know, we may need to do a silver nitrate application. Or in some cases, if the hypergranulation is too big, then you might need to do like a surgical debridement or cauterization. But this is a great picture. This is a classic hypergranulation, so you can see this sort of spongy material at the stoma site. And again, that is not something that should be there. And if you have hypergranulation and your doctor said it's normal, I would argue with that. So I would recommend talking to the physician about trying the hydrocortisone cream treatment for a couple of weeks, see if that makes an improvement. But the first thing I want to look for generally are clues as to why is that there. So if this bolster is set too far back, then that tube's going to go in and out and in and out, and that sliding back and forth is what causes the hypergranulation. And this is another good example of that. So you can see the proud flesh there. And this picture shows, my first question was, is this where the bolster always is? And in this case, that's where the bolster was always set. So you could assume very easily that it was moving in and out and in and out, and that movement is what was causing that hypergranulation. So last but not least, and there's a method to my madness here, we talked about bacterial infections first, right? And then we went into hypergranulation second. And now I want to talk to you about yeast infections, which I actually see more often than bacterial infections. The reason I want to talk about this last is that untreated hypergranulation can actually lead to yeast infections, because that hypergranulation bleeds very easily and that moisture can actually grow yeast. So these are sort of the clinical descriptions of what yeast is. I'm going to show you pictures of it. But it's generally pretty obvious, and yeast infections can hurt, where bacterial infections don't usually hurt. So if you're trying to figure out what sort of infection do I have, that's one of the clues, because that's really what we're doing, is assembling clues to figure out what's wrong with this picture. But the common causes are excessive leaking at the stoma site, so making sure you have a properly sized tube is really important, or the bleeding from the hypergranulation, or if a patient is sweating or it's summertime in the south and you're not in Newport Beach with nice cool breezes. Sometimes, if it gets too hot and we're sweating, then that can grow yeast, which is really a perfect, what's the recipe to grow yeast? You have a warm body and some moisture and it's covered up in the dark. That's how you grow yeast. So it's important to keep that tube site nice and dry. So the treatment options are pretty straightforward. If it's leaking, you want to put a barrier cream on there to protect the skin, but you want to solve the problem of the leaking as well. Hydrocortisone cream, if it's very red and inflamed, a topical application can help manage the red inflammation. And then, of course, an antifungal treatment. And so you've got 3 different creams going, and you've got to apply them all throughout the day. So putting them on rotation is a really good plan, and making sure you wipe off the barrier cream before you put the antifungal on. And so I wanted to talk to you a little bit about the two main options that I am generally recommending. Lotrimin is an over-the-counter version, or nystatin is a prescription version, but they're interesting in that they both operate on the yeast cell wall. So what Lotrimin does is it actually blocks the manufacturing of the ergosterol, which is a critical material of that yeast cell wall, and that's how Lotrimin kills yeast, where nystatin actually attaches to that ergosterol and then pokes holes in it, and then the yeast eventually dies. So it's very effective, and either one will work. And they come generally in either a powder or cream form. And so here's a picture of a yeast infection, and you can see the red erythematic area around. Here's a little pustule. You can see sometimes it looks like peeling skin. That's another clue if you have that sort of peeling skin look. But there's another little clue on here about what is causing this yeast infection. Who sees the clue in this picture? Hypergranulation. Do you see it? It's right there. Look how teeny weeny that is. It's so tiny. It's the tiniest little bit of hypergranulation, but it's so vascular and so fragile. And that's what really caused this yeast infection. So what do you do for that yeast infection is you treat it with the 3 interventions that I talked about. And you can see with this example, this case study, patient had significant improvement in a month and a half. And we were able to salvage that G-tube site. So the barrier cream, we've helped fix the way that the tube was setting so that it stopped leaking, slowed down the tube feeding so it wasn't leaking out as well. And then did the barrier cream and then nystatin. All of those twice a day, every day. Yes? So I recommend, I'm a strategist, I'm a very pragmatic practitioner, but for me it makes the most sense to put the nystatin on or the antifungal on for the longest period of time. So that's the one I would put on at night, so you have the longest exposure, and then start your rotation from there when you wake up. And keep it practical. Don't wake anybody up at 3 a.m. to change their cream or anything like that. That's a great question. So we've finished talking about bacterial infections. We've talked about hypergranulation and yeast infections. Now I want to talk about other real-life things that occur for us in home care, and that's mold in tube. Has anybody ever had mold grow in their tube? Oh, you guys all are excellent home tube feeders who are flushing their tubes very well. So that's the first indication that maybe there's an education required around flushing the tube, but you can see the little black stuff growing in there. And it's not an emergency if you have mold growing in your tube. That mold has become embedded in the tube, though. That's important to know. You're not going to be able to scrub it out. Don't put anything in there to try to scrub it out. But do schedule an appointment to have a tube replacement, because what will happen is that tube will become brittle and it will crack, and it will crack on Friday night at 10 o'clock. Right? Invariably, of course. So recommending proactive replacement of that tube if you see mold growing. And then just remind whoever that is that would be good to flush using what I refer to as a water sandwich technique. So anything you're putting through your tube, put water, feeding, and then water, and keep that tube nice and clean. And then this was another example of a tube that was not flushing well, so I couldn't quite figure out what was going on with this at first because they were flushing it, but this wasn't going away. It was sort of adhered to the tube, and so what we figured out is that it was actually degradation of the tube, and it was time for that tube to be replaced as well. This is a quick picture of a tube securement device. So this is a tube that does not, it's a catheter style tube that's sutured in, and there's no bolster there to stabilize it. So it's a wise decision to have something stabilize it. So this is an example of what's called a stat lock, and that sort of shows how that tube can be stabilized so it's not flopping around and creating hypergranulation. There's another example of a catheter stabilizer, so that can be used as well. And then this is an example of a patient, they actually had a catheter placed as a feeding tube, and the problem with this is that tube was in so far there was nothing to work with here when it was time to connect and feed. So we solved that little problem with an extension adapter. There are lots of different adapters and things out there to help solve some of these problems. This was another example of sort of a hospital setup. So you've got this actually doesn't connect. This is one of the reasons why I'm actually looking forward to NFIT, because MacGyver, does anybody know who MacGyver is? Some of you do. I have to be careful with that reference. Not everybody knows who MacGyver is. But it's being remade. Thank God for that, because I'll be relevant again. So this lure lock connection does not really work with this 3-in-1, this stopcock. So it was sort of leaking there. And so we got that patient an adapter, the appropriate adapter, and plugged into a lighter weight extension, actually with this little purple guy up top, because these can be sort of heavy. The stopcocks here can be very heavy and weigh down on patient and can actually cause hypergranulation because of that weight. So in home care, we have other lightweight portable options for patients that can really just change their life, and sometimes it's as simple as an adapter. So the bottom line is, if it doesn't look right, it probably isn't. And you do have options in home care with your feeding regimen. And so, like Elaine was talking about, she was asking earlier about, with NFIT, sometimes we're concerned about people feeding too fast. And that's one of the things that we have to do to help people sort of tolerate things a little better and improve their quality of life. We do know that complications do occur, and it's critical to have a village of knowledgeable people around you. So your home care clinicians, hopefully your provider, your physician, any of the nurses in clinic to help you solve those problems. So that concludes my presentation, and if we have questions, I will field them.
See how thorough that was?
That was so good.
I told you, she sees things that will keep you up.
As part of Oley, I take phone calls from people that have questions. You would not believe the number of people that are sent home from the hospital with nothing.
I do
Absolutely nothing.
Mm-hmm.
They have no information. They have a tube put in one day and they're sent home the next day with a can of formula. I had one girl call me. She had one can of formula and was instructed to do 250 milliliters at a time.
Probably with no instruction on how quickly or slowly to administer that. I see that a lot. I hear you. I feel very validated right now, so thank you for saying that. But, the lady with the bacterial infection was a really great example of that. She was that person, went home with a 12 cc syringe and was buying an oral supplement at the store and fed that way for a year, and had a bacterial, and was seeing physicians replacing the tube. Help me understand that. So it's, like dietitians, are you still in here? Raise your hand. Okay, you're a part of my village now, right? You guys are in my army. You've been recruited. So to educate out there that if it doesn't look right, it probably isn't, and it doesn't there is support out there for you in this community and in the healthcare community.
Cynthia, there's one point that you've made that earlier in my career I would have agreed with, and now I think it's in question. It basically is, how much should you have a tube that's, quote, just right? There is data Steve McClave has particularly looked at in terms of being a gastroenterologist, looking on the outside and on the inside, which shows that irritation around the tube is strongly related to having it too snugged up. That causes irritation on the inside. It then causes it to spread up around the tube and to the external surface. So it's a kind of secondary thing what you're seeing on the outside. And so I think most of us would have wanted to have something that was fit about right, but the data does not support that. It shows that if you have a longer tube, which really isn't snugged up that much, you have a better chance of having less trouble on the skin. And it's counterintuitive, but it's interesting.
Yeah, it is, and this is one of the things that we have to assess when we have the complaint of a leaky tube as well, because it's a fine line. And it's also sort of a bit of an art when the initial placement is done, because the patient is laying down when the tube is placed, and when they come home they're up and moving around. So there's some anatomy change there, and it can be too tight just on that initial placement. But after that tube is matured, and you don't want that pressure, you don't want that bolster too tight sitting on there, but you don't want it so loose that the balloon or the bolster on the inside of the stomach lining is allowing leakage to come out either. So
I think that's the point that I was trying to make.
Yeah.
It is counterintuitive
Mhm.
that actually the further the balloon is in, is the less the problem, because the real irritation starts on the inside.
on the inside.
So I certainly had your opinion for 90% of my practice, but eventually I was convinced that Steve McClave's data is interesting.
That was fabulous, first of all. I heard you do
Thanks.
something similar a while ago on one of the quorum conference calls, I think. And
Yeah,
this was,
a lot of this is from
yeah,
that.
well, but this is even better. And it's
Oh,
helpful to
thanks.
see you hold up the bowl of water. Anyway, long story short, getting a low profile tube changed my life. And it wasn't until a really great interventional radiologist sat and listened to me and was curious about my tube and why I had it and if I liked it and whatnot. And so I guess my question to you is, while a low profile tube is not the best option for everyone, it can change people's lives. I know for me it did.
Yes.
So how frequently do you talk through with your patients, consumers, whatever, and bring that option up? Is it something you do commonly, or do you think it should be done more? What could we do as Oley ambassadors to help support that effort? Just a
Yes,
thought.
that's a great. I was actually talking to a lady yesterday who was having some challenges, and she's a long-term tube-fed patient and has a longer G tube. And she was explaining to me how she's worried about her dog because her dog will step on it. And I said, you realize you have an option, and her physician is resistant to placing it because he needs to measure, and then it's a thing, and you got to come back in, and it's right. And I said, they don't want to do it always, but you have to persist and find a physician who's willing to place it, to measure it, have a stoma measuring device sent out if that's needed. But when we have a patient who has a longer, permanent tube in, they can't just take it out and measure. But our button patients, it's easier to confirm the size by sending out measuring devices. But I think you're absolutely right, because the buttons have been perceived as really only for pediatric use. And we're trying to change that, because there's a quality of life factor, and there's a population of patients that would really benefit from transitioning to that, and it gives them, well, these two, I actually asked Debbie and David, how did you get a button? Because they are that population. They had the longer tube. So David was on a feeding tube prior, had graduated off, and then had to start up again because his swallowing had failed again. And he said, I am not doing this unless you have something else, because I don't want this thing hanging out. So he demanded it. Well, then Debbie was in IR. She proactively getting her tube placed out every 3 to 6 months. And she was chatting up the IR tech and said, what other options do I have? And that's how it came up. She had to advocate. So they're in there, in that procedure room, doing a procedure very focused on that. I want to open people's eyes up to the home care journey and what happens outside of that procedure room, and how these decisions impact quality of life moving forward. But it's going to take a village. And so now you're all in it. So, thank you.
Thank you very much, Cynthia. And you're right. it's amazing everybody's perspective, and everybody has a different view. Moving along, those of you who notice I stopped feeding and don't have my bag on get extra points at the end of the evening. But the point is, you can do it, and you just get used to it. My biggest challenge was making sure I had both a brown bag and a black bag, so it always matched my shoes. What can I tell you? Our next speaker and presenter is the executive director of GEDSA, and once again we'll bring NFIT back, and this is the association or the collective of the manufacturers. So I'd like to bring Tom Hancock up, and at the end of the presentation we're going to have some samples and so on from the different manufacturers at the table on that side. We're disagreeing if it's stage right or left. We'll go both. There's so many, we'll go stage right and left, so I don't have to figure it out. Thank you.
Hi. Thanks for coming, guys. I appreciate it, and thank you, Oley, for having me. So I have what the proverbial 20 pounds of material in a 5-pound bag. So I've got a lot of information that I want to share because I know there's probably a broad span of understanding and knowledge and kind of what's going on with NFIT. So that's kind of my goal, is to just try to capture kind of a background for people who are not aware of what's going on. I think many of you in the room. How many of you are familiar with NFIT? Pretty much everybody? Okay. So we'll do a quick review. I'll do the speed round on that, and then we'll get into some of the hot topics, I guess we'll say. And then as long as everyone's willing, likely my talk will be 20 minutes, so that'll be 5, which is when the session's supposed to end. But if folks want to stick around to do the hands-on from all the manufacturers, you can do so. The other option is, of course, they have exhibit time tomorrow. You can stop by their booth as well. So topics for discussion today are quick background, timing and implementation logistics, dose accuracy, blenderized tube feeding, some recommendations, and then Lisa wanted me to cover reporting adverse events and any time for questions as well. So GEDSA is the Global Enteral Device Supplier Association. And so that's such a long word, that's why we always say GEDSA. Our mission is to promote initiatives surrounding safe and optimal delivery of enteral feeding and connectivity. It's important to note that I'm not GEDSA. GEDSA is a very large organization made up of all these manufacturers. Some of these names may look very familiar to you, some may not. Companies have merged, names have changed, and then there's several companies up there that might do business outside the United States, and that's really to underscore that this truly is a global initiative, and that's why you see the picture of the globe there. Supporting organizations, there's a number of them. I don't think I actually listed half of the groups that are engaged and involved with us. We have tons and tons of folks that advise, that provide feedback, that offer ways to raise awareness of this. Oley's been kind of involved and with us since the beginning, providing lots of feedback, offering ways to update the community and through newsletters and events like this. So it's definitely very appreciated. Some of the other, alphabet soup of associations you may not be familiar with, but there are various groups that represent nursing, pharmacy, doctors, etc., and then institutions like GPOs and so forth. So Debora had a wonderful presentation this morning. Hopefully you guys all saw that. I do want to underscore a couple of events, really just to remind us all again why we're doing this. And tube feeding misconnections and adverse events. Here's a couple of examples. Things to continue to stress is this is a grossly underreported event. Events that happen. There's all kinds of near misses that never get reported, and there's all kinds of events that have happened just in the last 10 years, and that's what this list is. And you'll see there's all kinds of examples. IV tubing misconnected to a nasal cannula, feeding tube to a tracheostomy tube that resulted in a patient death, epidural infusion set connected to a peripheral IV line, resulting in a patient death. Feeding tube connected to an inline ventilator, suction catheter, again, resulting in a patient death. The heparin lock connected to an automatic blood pressure cuff, resulting in a patient death. And then this was the example that Deborah provided this morning, a horrific example of a pregnant mom with their expectant 35-week-old fetus, and neither of them survived because of a tubing misconnection. So it serves as a constant reminder as to just why we're doing this, and wanted to make sure we touch on that before we go any further. So I want to kind of take it from where Deborah kind of left off to where all the other efforts. So she did make a very important point that frankly this thing has gone on for 10 years and that's too long. So I want to provide not an excuse, but rather just a little bit more context of why things take some time and some issues that we had to work through. But this is a standard, this is a series, in fact, of a small bore connector standard. And it brings together technical experts, clinical experts, and regulatory and standard experts from around the globe. And just getting the group together and having a conversation is hard enough, but then you have to define the problem, you have to define potential solutions, you have to look at those solutions, optimize those solutions, validate those solutions, and do all kinds of performance testing to make sure you feel good about where you're at. The other thing that's really, really important to recognize is this series is intended to reduce the risk of a tubing misconnection. It's not going to eliminate that potential. Okay, so I want to remind everybody that. There's so many devices out there, they're proprietary devices, there's the lure lock, there's all kinds of connectors that are out there, that we'd have to basically wipe the slate clean and start completely all over again to completely eliminate a misconnection. So again, what we're doing is reducing the risk. And it's also important to note that we have to do this over time. Enteral is the first in a series of connector changes, okay? So I call them swim lanes, right? So you have respiratory, enteral, urological, limb cuff, neuraxial IV. Think of them as swim lanes. So each of those groups have their own connector that connect within the group, but not with any of them else that are represented up there. And of course, the goal is to try to make sure they don't connect with anything else out there, like a tracheostomy tube and other devices. The series started with these 6, but that's not where it ends, right? That's the starting point with the greatest risk. There are more devices, there are more standards that have to be done in order for us to truly solve the problem. The question was raised earlier this morning. What about a trach tube and an enteral feeding device? Well, we've solved the problem on our end. Challenge is you've got a tracheostomy category, if you will, that hasn't defined their limits. So you can have basically a funnel, if you will, that can accept any one of these connectors right now. So until that tracheostomy group defines their connector and what that standard looks like, there is a potential for a misconnection. So we're improving the situation. We're not necessarily going to get there. It's not going to be perfect. And Deborah's quote this morning, I'm going to get it wrong, but perfect is the evil of good. I think it was something like that. So we are improving the situation, but it's not ever necessarily going to be absolutely perfect. So it's important to consider that. Requirements, not connectable with others in the series. Rigid or semi-rigid material. It passes all these misconnection risk analysis, usability, human factors testing, and of course, not connecting to a lure. Here's some of the testing that was done. So it's purposely a laundry list because I want to illustrate for you just how much work went into essentially the development, the proof of concept, validation, performance testing, et cetera, that went into this design over several years. So you have clinical assessments with physicians, nurses, pharmacists. You have usability and human factors testing. You have misconnection assessments, which is basically identifying a misconnection, whether these two things can connect, and if they do connect, will it cause a greater risk than what exists today? Syringe accuracy report, user surveys, acceptability and suitability studies. We did a whole host of testing around the low-dose tip syringe, which I'll get to in a little bit more detail. And then we have a really practical, real-life lab, if you will, in the United Kingdom, where they actually did change the design of the connector for enteral feeding What they did is they took a lure lock and they reversed the orientation. And they did that with quite a bit of success over the last 10 years. Suitable for that market because it's small and fairly defined, but doesn't really solve the problem globally because you still can take a lure and connect to it. Not nearly as likely, but it does help us directionally know that we're heading in the right direction with NFIT. So that's a little bit of synopsis of years of work that went on in the standards effort. And we created the 80369-3 connector, which we thought really rolled off the tongue, so instead of that we call it NFIT. NFIT, EN for enteral nutrition, FIT for fitment. And that's really intended to be the shorthand for the standard, but it also specifies the direction of flow. So female to male, we'll get into that here. So you have the current system. Everybody's familiar with the step connector on the left-hand side that fits into a female connector on the feeding tube side. And it's a female, typically very flexible material. And the challenge with that is just it accepts just about anything to go into that connector right now. So we go to NFIT, which is the, again, female on the administration set side. Oops, I did not do that right. The female on the administration set or syringe side to a feeding tube on the male side, male feeding tube. So we reverse the orientation. Also, it's very important to note that we have a transition period. It's uncertain as to how long this will be, but we know that tubes are in place. Thank you for the last presentation. Tubes are in place for months and sometimes even years. So we don't want to have unnecessary procedures. If a tube is placed and is just fine, we don't want to cause tubes to be replaced only because of a connector change. And so that's why we have this transition connector with the steps on the one side and the other side is the male NFIT. So it allows what we call backwards compatibility. So the administration set, again, has the pump sets, gravity sets, other bolus feeding devices will have the female NFIT, and then the male part for NG tubes, G tubes, low profile extension sets, the J tubes, PEG tubes, etc. will all have the male part. And then, of course, syringes, and that's the key. So whether you're talking about a 12 ml syringe or a 60 ml syringe or whatever you choose to use for oral, for administering medication, flushing, hydration, bolus feeding, etc. So today it's an oral or catheter or sometimes even a lure slip. In the future, it'll have to be enteral specific or an NFIT connector on the end. So a little bit about timing and implementation. So Deborah mentioned before that this thing has slipped and it's delayed, and I could tell you all the gory details as to why that happened, but there was issues related to supply, particularly of syringes, and then there was issues of dose accuracy. I'm going to try to touch on both of those. So today we're standing at a point where we have transition sets that have been out there. Many of you have seen them, if not all of you have seen those for over a year. And now we're ready upon us to have syringes as well as feeding tubes. And essentially what GEDSA is recommending is the introduction of these devices as soon as possible with adequate supply. So I share this slide because it's really important. You might be sitting back thinking, well, I saw all these pictures of like NICUs and ICUs and discussions about all the lines that can go into a patient. Well, that doesn't typically happen at home. Why do I have to suffer through this transition? And the reason is because patients travel. Patients travel between healthcare settings, hospitals to nursing homes to home care and back and forth. But you know, thankfully, today, more mobile, they're traveling across state lines and even across countries, various countries. And the portability of a patient is really, we want that, right? We want people to be mobile and moving around, but we want that care to be consistent, and we want to make sure that there's no deprivation of therapy. God forbid you're traveling and something happens, you will go to a hospital, you want to know that whatever devices they have in their hospital will match what you have. And that's really the key and why you can't isolate this to being just a hospital problem. So the other complication from a supply chain perspective, and that's the stuff that we worry immensely about, the members of GEDSA, that may be more difficult and challenging for you all is to understand is that you're really talking about a system that is likely coming from several different manufacturers. So just the simple schematic over here, the nutrition or the bag comes from company A, the administration set may come from company B, the syringe from company C, and then the feeding tube from company D. And this little diagram is the core reason why GEDSA exists. It's because one manufacturer can't choose to introduce this one year and another manufacturer in another year because these things all have to fit together. And perhaps the only thing worse than a misconnection is when someone can't be fed at all, right? So we need to make sure that these are compatible, they work together. And we have to work through issues like inventory levels, connection between the suppliers, and other types of additional issues that have to be worked through that you'll have to understand is relative to changing the product codes, things like excess and obsolescence and returns and things like that. So that's really what caused some of the thinking. I'm going to share this purposely complicated cartoon here. But basically what it illustrates for you is I mentioned the timing of 2016, and I was careful not to say July 2016 or even December 2016 because the answer really does depend. And it depends on how that product ultimately gets to you. What you typically see is that little box at the end where there's a little home there, and you see the product show up from somebody's little yellow car or van. But really, if you look back, there's all kinds of things that have to happen. You have component manufacturing that then gets shipped, that then gets to a finished good manufacturing, that then gets shipped to a warehouse for a manufacturer, that then gets shipped to a distributor, that then gets shipped to another warehouse, that gets shipped to all these places, right? And there's inventory every step of the way, okay? So you might have a day, you might have a week, you might have a month, you might have a year's worth of inventory. So the answer really is going to depend on when you will see that tube, that syringe. I would anticipate that if you live in California, all of this will be significantly expedited to try to meet the California legislation and perhaps elsewhere, because what we don't know is when that next event will occur. But when that next event occurs, Deborah's already convinced me that she's going to be testifying on behalf of that individual that had a misconnection. And every manufacturer better watch out if that's the case, because we do have a safer solution in front of us, and it's our job to make sure that's implemented. But back to the village comment, it's up to you guys also to make sure that, as we say in the industry, gets pulled through. That you guys adopt these things, introduce them to your patients, and the patients ask for them by name so that this all happens. So that's a little bit of kind of logistics and timing. I can't really be more precise than that, and that wasn't precise at all, so I understand it. But the best thing you can do is then, again, just be an advocate for this. You want to see this change, and you want to see the products when it's time to replace your tube with the new ENFit connector on them. So I want to get into dose accuracy. So that was one of the key reasons why you saw a delay in the introduction of ENFit. So the concern around dose accuracy was that if you take a typical ENFit syringe, you have, well, actually any syringe, you have what's called dead space. And dead space in and of itself isn't a problem because every syringe has it and it's calibrated within the markings on the syringe. The problem exists when you have dead space that interacts with the tube. And in the ENFit case, you have a male tube that is pushing the fluid that's in the dead space on the female side into the syringe, then causing it to be actually delivered. So you have a potential for an over-delivery. In other situations, you have an under-delivery problem. So you have a dose accuracy concern. At the time, manufacturers said, hey, we can solve this with a protocol. And that was very quickly shot down because we don't need another protocol in a hospital or any type of nursing environment. What we need is a device to solve the problem. And that was the feedback we heard loud and clear. The other reason I want to share this information is it's a really good case study, if you will, on how well I think GEDSA manufacturers work collaboratively together to solve a problem. Because what happened is we heard these concerns, and then industry looked at this and said, well, gosh, there's no standard today for dosing accuracy, so how are we going to solve this? Well, they went a next step and basically defined that with all kinds of benchmarking. So what the group came up with was what we call an ENFit low-dose tip syringe. And basically, if you see, there's actually a male part on the inside of that traditionally female ENFit connector on the end of that syringe. And it mimics what you see on the bottom. So in the left part, you see the lure lock in that photo. And to the right, you see the ENFit low-dose tip. And the two are very similar, I'll say design-wise, right? They have a male lumen and then an outer collar. The difference, of course, is dimensionally that those two will not be compatible with each other. So the design, though, we know works effectively because it's worked well for lure for years. And so that's the design that was identified, and then a whole lot of performance testing was done at an independent lab. And what we see is that in that purple bar, that's the ENFit low-dose tip, and then what we see is the dimension. So what we're showing here is the plus or minus delivery accuracy. So you see negative 3% to positive 10% in terms of your dosing accuracy range, which was strikingly similar to the enteral/oral syringes used today. And in fact, 3 different manufacturers were used in the testing, and this is kind of a combination of all that data that shows a negative 7% to positive about 10%. So the 2 bars, the purple and the blue bars, are very, very similar, and in fact, statistically the same from a dose accuracy perspective, all within that plus or minus 10% range. And by the way, we're talking about accuracy plus or minus 10% in volumes as little as 0.2 ml, so very, very small doses. If you're an adult and you're delivering medication, chances are you won't need the accuracy to this level. This is really more likely to be for a neonate in a NICU environment. We also looked at that relative to reverse orientation, the reverse lure in the United Kingdom, and then a proprietary system. And both of those devices have been used extensively for years. I'll say in air quotes without issues. I can't say definitively because there's, again, probably poor reporting relative to dosing accuracy. But those 2 devices were used, and you can see the accuracy is significantly greater, error range, I'll say, than the ENFit low-dose tip. So a very nice solution. The performance testing showed that the dosing accuracy is plus or minus 10%, substantially equivalent to the standard orientation enteral syringes that are used today. It performs better than the reverse orientation syringes that are used today. And then another key note from our performance testing is that the use of an adapter, a drop straw, a cap of some sort, does provide greater performance than a cup fill. We did the misconnections and usability to show that there was no greater risk in a misconnection with this added inner lumen, and that the usability demonstrated consistency with use among nurses, caregivers, pharmacists, and the whole group of users. And the other great news is just a couple weeks back, we learned that the FDA cleared these low-dose tip syringes for 2 different manufacturers after very, very thorough review of all the data and analysis and validation. So we're pleased with that. So I share that for a couple reasons. Many of you have heard about dose accuracy concerns. The low-dose tip does appear to address that quite substantially, and then also shares from a perspective that this is a good collaborative effort. So I move on to I'll say challenging topic for some of the folks in the room who wish to blenderize their tube feed and deliver that. It's a growing trend, one that I'll admit that many manufacturers that are part of GEDSA were not aware how significant that usage was. And so we're all learning. We're all learning how prevalent it is and how best to help those patients, whether that's with ENFit or other potential solutions. So you've seen all of this. I'm not going to repeat what Dr. Mundi shared. Great work that's going on at the Mayo Clinic, as he mentioned. There's also great work going on with the FDA, essentially validating each other, looking at the same protocols, doing some of the same testing, both from a flow rate perspective as well as looking at it from a force. So how much pressure is required to deliver with legacy devices versus ENFit devices. GEDSA, Oley, others are kind of tuning in, listening in, providing perhaps some support from a standpoint of product, and then blenderized diets, the actual diets themselves to test. But the actual testing is being conducted by Mayo and from the FDA. The The other thing that Dr. Mundi mentioned is we're doing I would say a fairly thorough questionnaire. In my past life, we called those habits and practices. So you do a lot of questions and you share those with users, and you understand how things are being used, what types of practices are being done, and then if there's opportunity for greater learning or greater growth, we'll be able to uncover that. There's about 50 questions that are being shared through Oley, through Feeding Tube Awareness Foundation, and other channels, just to get a much better understanding of kind of how things are being used today. And I would say, what do we want to do with this? Well, we think it could lead to many things. One, just much richer understanding for industry. There are a lot of manufacturers, I'll speak on their behalf, that they were really shocked and surprised to see the kind of volume and kind of level of usage among blenderized diets, and that's a good thing. But you know, the thing we really want to do is, and I mentioned the dose accuracy piece, really from a standpoint of look what we can do if we put our minds to it. There is a group from a technical, commercial, regulatory perspective that is just top notch. I've seen them in action so many different times, and hopefully some of you guys will attest to it when you've seen them in action. And they do fantastic work, but the fact is, anybody really needs to have a really well-defined problem statement in order to have a good solution. And what I will tell you is, I don't think there's a good enough understanding of the problem. Is there a problem? And if so, what does that look like? Is there a potential delay in feeding? Is there greater force? Is it in certain types of tubes, certain French sizes, certain material? What is the situation? So until we better define what that problem is, we can't really solve for anything, right? So I think it's really important to understand that. We also, but through the habits and practices work, are there recommendations that we can offer up and best practices? Because I don't think this is necessarily an area where many, I can't say all, but many dietitians, nursing, others that provide care really are able to provide really good input and feedback and do this and don't do that. So if we learn more, collaboratively, we can work well together. So, and it's not just industry, Oley's involved, Feeding Tube Awareness, several of the home infusion companies that are represented here are actively engaged to learn about this together. So it's very encouraging. Yeah. Okay. I was so close to finishing on time. I'm sorry. I was trying to move fast, but I got caught up a bit. Okay. All right. I got just a couple more slides, and I'm sure there'll be questions. But so back to the last slide, there's a lot to learn. There's a lot to have better understanding. If there's a problem statement, let's define it. Let's figure out what that is, and then, if there's solutions, there's all kinds of options to look at. Until that time, I share this slide, and there's others, I'm sure, but I have letters from 2 manufacturers as well as a statement from a third. You can certainly ask the other suppliers that are in the booth space what their plan is, but the 3 that I mentioned here all basically state that they will continue to offer their legacy devices until further notice, and they're not even giving a time because they want to know more about this opportunity/challenge before they make any commitments one way or the other. So I think that should make folks feel a little bit better that these legacy devices will remain in the market, I'll say indefinitely. And make some feel a lot better, and make some feel worse, because the downside of that is that the longer you have a legacy device out there, if it's for years, the greater chance that that could have a misconnection, and B, the problem that ultimately, if there's no transition connector, there's no adapter, then there may be deprivation of therapy. So it's a double-edged sword, but we know that would be something that's important. I've actually had requests from Oley to learn if there are manufacturers and what their plans are. So there's 3 good examples, and I'm sure there's others at the exhibit booth that you can ask. So recommendations. Really big thing is work with your home health or infusion supplier. Are they prepared? If the answer is no, we'll have them reach out to us or reach out to Stay Connected and learn more about it. Hopefully we've done a decent job raising awareness, but we know there's still many out there that haven't heard about NFIT. If yes, make sure you understand their specific NFIT transition timing for all of their tubes and syringes, and make sure that they have the right components for you and what you need, because they're hopefully doing their best to make sure that they have their suppliers getting them ready. But if they're not asking the right questions, then they may not have the right components. So be an advocate for yourself, advocate with your home infusion companies to make sure that they're well prepared. I mentioned the syringes. Again, I don't think it affects you all for the most part, but if you have a neonate or someone who needs extremely small doses of medication, you may need to have a low-dose tip for something like a 5 ml syringe or below. And then again, from a syringe supply perspective, make sure that there's adequate supply to meet your demands. And then stayconnected.org, it's a continual plug. There's lots of information there. There's a Stay Connected newsletter that you can go to. It goes out at least once a month with updates, and hopefully more frequently. There's all kinds of checklists and things that you can go to there. Lastly, I want to cover reporting adverse events. So this is something that's very, very formal for manufacturers. It's an obligation and a requirement for every manufacturer in their quality system to have a way to handle complaints. Okay? So I'm not saying it's going to happen, but if it does, I suppose it's okay if you go to the blogs and complain about it. It's more important and it's more impactful if you go to the manufacturer, because the manufacturer's job is to define if there's a problem, and if so, what it is, and if so, what's their corrective action. And that's their obligation to the FDA and to all of you. Each of them have their own very specific procedure and protocol, so I can't give you precisely what to do. The best thing I can tell you is reach out to them. They all have information on their websites to how to contact them. And the kind of things you want to communicate is the age, the gender, the medical condition, description of the event, list of all the devices that were used, and then any product identifiers, brand names, model numbers, lot numbers, things of that nature. I would say that's kind of the core of what you should expect to be asked. But I think, in a way, it's your obligation as well to make sure that we have a safe community to communicate to the manufacturer if there's a problem. So, thank you. Good segue. So the one thing to keep in mind is if you report it to a manufacturer, the manufacturer then has to communicate it to the FDA. So it will get to them either way. There's certainly no harm, no foul if you communicate it directly to the FDA, and they offer ways you can do that. There's a link here for voluntary reporting. There's a phone number, and they'll ask you the similar questions that were on the previous page on how to report an event. Okay? So those are my prepared remarks. What questions does the group have, or do you want to go to the...
Actually, has everybody got their children in child care? You're good? A couple questions, and manufacturers, do we want to do that here, or just maybe do it tomorrow?
It's up to the group. Do it here? All right, how about this? Quietly go to your tables, and if there's questions, we'll get those covered.
It's certainly one of the hot topics, and a lot of work.
Any questions? Sure. Hey guys, while you're setting up, keep it quiet, please. Maybe that wasn't a good plan.
First, I'd like to thank you for a very informative presentation. I really appreciated that.
Thank you.
My comment relates to the issue of blenderized food. What I don't understand is how so many people at the upper levels of the profession could get together in GETSA and so miscalculate the people who are using it in the general population, that they wouldn't have taken into account the use of blenderized food in this redesign, and that would have created this type of an issue where the end users, that is the feeding tube users, are almost frantic about this change because they feel it's going to force them to use commercial formula. And nobody trusts anybody anymore. So the fact that there are members of GETSA who are commercial manufacturers of formula is very suspicious to these feeding tube users, because it looks as though these manufacturers have just changed it in a way that will help boost sales. And I was wondering if you could comment on that.
Yeah, so several, I guess, questions or things related to what you mentioned, so I appreciate that. Let me first tackle the last comment. I would say there's nothing further than the truth that there is some kind of conspiracy to sell more formula. If you look at that list of manufacturers, at least in the United States, 2 of the almost 40 manufacturers in the United States offer formula. The rest are just device companies. And so the device companies are in business to sell devices. They're not in business to sell formula. And so nothing could be further from the truth. And if we're talking about a patient safety initiative, I think that could be completely irresponsible. That's my comment. It's my opinion. I mean, others can certainly chime in on that piece. But I just, that one probably bothers me perhaps the most. I used to work at Abbott, by the way. And Abbott was, I'm involved with GETSA because Abbott was involved in this initiative, and Abbott wanted to see a safer solution, as did every other company. And it was never, ever, ever about selling more formula. So I actually take a personal offense to that. But the other comment was, why did we not take into consideration blenderized diets? I think that's also a false statement. We did. There were companies that worked with collaboratively, again, together to do flow rate testing, to look at this potential concern, and found that for the vast majority of tubes in the French sizes, there was no difference in flow rates. So in fact, what Mayo is doing and what the FDA is doing is more validation work that was already done as part of the major amount of input into the validation work that was done initially. Perhaps we didn't know how big it was, but we knew that blenderized diets was certainly A, concern, and B, something that we had to look very carefully at. So I don't know if anybody, Don, or anybody would like to comment on the past testing.
I would just like to make one
Yeah.
follow-up question, and then I'll pass it along to other people who have
Yeah.
questions. And
Yeah.
that is that if what you're saying is correct, I appreciate the fact that you don't like the conspiracy issue. Okay, let's put the conspiracy issue to the side then. If what you are saying is in fact correct, then the GETSA community has done a terrible job of communicating that to people who use blenderized food, because the people I've spoken to are convinced that this is going to cut out a basic human right, which is to choose their own food.
So I think what we do is our best to communicate what we think is appropriate, and there's some communication that's going on out there that I will tell you myself, through my lawyers and manufacturers from their inside counsel and outside counsel, they're asked not to comment, because the comments that are being made in the various environments are inflammatory, and it just gets you in trouble. So we're actually counseled and coached not to communicate anything. So if you want to blame someone, you can blame me that I didn't do the proper job to communicate that all this work was done. But I will tell you, manufacturers are look at all the folks that are here. They're here because they want to see a better solution, or understand the problem first and then see if there's another solution out there. And so I don't know. I'm not sure I would have done anything different, But I do know that there are several companies, myself included, that were asked and told not to comment on things like that because of everything that was so inflammatory about the conspiracy theories and so forth.
Thank you, Tom. Let's cut it short. And Tom and everyone else involved is certainly available for the duration of the conference. So feel free to buttonhole everybody and anybody. Tom, thank you very much. Just please, the different devices are on display as we have a smaller crowd than we would in the display room. Please approach them directly and ask your questions. And remember, tonight, 7:30 in the main hall is a silent auction. So bring your wallets, checkbooks, credit cards. We take children in trade, so whatever. But we want a good evening. And I thank everybody who participated. Thank you.